Assalamu alaikum. Good evening, ladies and gentlemen. It gives me great pleasure and honor to welcome you to our new episode in the General Dental Practitioner Lecture Series here at Hamdan bin Mohammed College of Dental Medicine. Whether you are online or present here in the audience, I would like to welcome you to this exciting scientific lecture. My name is Iyad Hussain, and I'm a consultant in pediatric dentistry, and I will be your host for tonight. Before I present or introduce to you our next speaker, and I'm very much looking forward to his presentation, I would like to take this opportunity to introduce to you the institution that we work in. This is Hamdan bin Mohammed College of Dental Medicine, and it's part of the Mohammed bin Rashid University of Medicine and Health Science. We are based in Dubai Healthcare City. We have a unique institution, and it was honored by a royal visit by His Highness Sheikh Hamdan bin Mohammed himself, where he attended the Dubai Dental Hospital, as you can see here in the picture. Dubai Dental Hospital is the clinical partner of Hamdan bin Mohammed College of Dental Medicine, which is a postgraduate institution. We offer multiple academic programs, and these are mainly 5 MSCs in different disciplines: endodontics, orthodontics, pediatric dentistry, periodontology, and prosthodontics. And these 5 programs are recognized by a plethora of organizations across the world in terms of health ministries, royal colleges, etc., as you can see at the bottom of the slide here. Besides the MSc programs, we offer residency programs as well, and particularly one stands out, which is the endodontic residency program, which was the first in the country to be recognized by the Saudi Commission of Health Specialties, and it's run by my colleague, Dr. Muhammad Jamal, who you can see here in the photo. The endodontic residency program is a 3-year program, and it offers the graduates a specialist title at tier 2 level, and later those who graduate can become consultants upon completing the required years of experience. And it is a structured and competency-based residency program here at MBIU. And as I mentioned, it's recognized by the Saudi Commission of Health Specialties. We also offer dental internships here as well, and they started in February 2020 for recent graduates from the dental schools across the UAE and the region. We have actually a timetable for admissions for the master's programs and the endodontic residency, and the applications for the master's opened in October the 15th, and they will close in February the 3rd of next year. The dental internship program application timetable will start at the February 27th next year, and the applications will close on the 29th of May 2022. Our dental hospital is a unique dental hospital here in Dubai. It's the only dental hospital in Dubai. It has 63 surgeries, and it offers treatment for all disciplines and specialties across the board. And obviously the treatment is carried out by qualified dentists, postgraduate dentists, under the supervision of academic consultants and professors. We take a lot of insurances, and the insurances that we take are listed here. So, you know, if you do refer patients to us, please consider the fact that we do take dental insurances. We're available online, on phone, on WhatsApp. So we have lots of socials here, whether it's Facebook, Twitter, or Instagram. But for those who want to refer patients to us, there's a WhatsApp number to contact here. And we operate, the standard operation time at the moment is from Saturday till Thursday, but obviously with the new rules and regulations, that will change, and watch this space. We're waiting for the formal announcement. Now, I'd like to present to you our speaker for this scientific evening tonight, and this is my friend and colleague, Dr. Abdurrahman Tawfiq, who is an assistant professor and a consultant in oral surgery at MBIU, and he's registered with DHA as a consultant and oral maxillofacial surgeon. He graduated from King's College in London in the United Kingdom, and he undertook a PhD in the prediction of mouth cancer at the Eastman Dental Institute in London, the UK. He also worked at a consultant level at several hospitals in the United Kingdom and actively contributes to postgraduate training and education here and abroad. Abdurrahman has a degree from King's College London in conscious sedation and uses this unique skill in the management of anxious patients, whether adults, whether children, and he performs a variety of surgical procedures under IV sedation. He also offers dental treatment under general anaesthesia as well. His interests include the management of impacted teeth, jaw cysts, mouth ulcers, jaw infections, dental implants, sinus surgery, facial pain, and anxiety. I leave you in the hands of my colleagues, in the hands of my colleague, Dr. Abdurrahman, and we look forward to this presentation. Thank you.
Thank you very much, Dr. Iyad. Thank everyone for attending. As Dr. Iyad introduced me, I've been working in Dubai here for almost 5 years now, and the service we provide is gaining momentum. Today I'm going to talk about complications associated with oral surgery and how can we avoid them or at least minimize them. The complications are so many, and I'm going to pick some of them because one lecture is not going to be enough. The objective for this presentation is to increase awareness of potential complications and pitfalls in oral surgery in dental practice. Also to attempt to provide guidelines on treatment planning and management of surgical patients. And I will be shedding some light on the possible pre, intra, and post-surgical complications. I will also share some clinical cases that I have experienced throughout my career. Some of them are mine, some of them are my colleagues, and I'll discuss the management of these complications. Finally, we'll appraise the ethical duty of general dental practitioner towards his patients and towards the profession. So, what is oral surgery? According to the General Dental Council in the United Kingdom and the Royal College of Surgeons, it is a distinctive branch of dentistry that deals with the diagnosis and management of pathology of the mouth and the jaws, which require surgical interventions. It involves the treatment of children, adolescents, and adults, and the management of dentally anxious and medically compromised patients. You can see here the core of competence of oral surgery is really wide. It starts from extraction of teeth, ending with management of dentoalveolar trauma, facial deformity, and even clinical diagnosis of oral cancer. The oral surgery in general is usually located at the middle of the picture, serving most of other specialties. So who can actually perform oral surgery? The General Dental Council did not actually say you have to be a specialist in order to perform oral surgery or any procedure. It actually states that whoever does this should be competent to do so as a result of appropriate training. So you notice I listed some of the common malpractice in dentistry in general. And if you go through them, they are all common sense. It starts from failing to get a proper medical history, treatment planning, or to do particular tests to aid to the diagnosis. And many, and you'll see later on in my lectures, many people forget to take consent, a valid consent from their patients. they assume that once the patient sat on the dental chair, he's consented for everything, which is not true. Another very important malpractice considered by the lawsuit that failing to refer a special condition to a specialist. There are so many other malpractice. I'm not going to waste time on that, but we'll go through them one by one later on in this presentation. I actually looked at some literature, newspapers, and I was very surprised. I saw that in the UK, we are really inundated with lawyers who are running after us in order to claim some money, but apparently it's everywhere in the world. And you can see that claims against dentists, they vary from 10% to 16%. To put this into practice, another way, at least 10 of every 100 patient, every 100 dentists at some stage will have some complaints and possibly lawsuit against them. Australia showed about 16% of their dentists were the subject of at least one legal suit throughout their career. So what are these complications? The complication can start from preoperative, from the time we see the patient in our dental practice, or during the procedures, either from local anesthesia or during surgery, or post-operative complications. But it's very important to know that the most important factors in these complications are the dentists themselves. Even though it's a human error, they still say that it is our duty to do our very best in order to avoid any error. Almost similar to when you fly an airplane, there is no room for error. I listed some of the preoperative complications. As I mentioned earlier, is failing to take a proper medical history or to do clinical examination, to do any supportive investigations, vitality test, blood test. It depends on the condition you are seeing, and also to form a diagnosis. It is very important after you examine the patient and to do all your investigations to put on your dental records what is your diagnosis, not just to go for the treatment without diagnosis. I know sometimes it's very difficult, but it is very important. Don't forget that patient can also collapse before any surgery, and it is assumed that every dentist practicing in the UAE will have at least BLS certificate. If you are involved in advanced surgery or conscious sedation, you are expected to have ACLS certificate. Failing to reach the standard of care expected is considered a breach of duty of care, and this is very, very serious indeed. The intraoperative one is starting from complications from anesthesia. I don't list every single one of them, but I just put two pictures here. This one, that the injection was so deep that reaches the subcutaneous area, causing vascular constriction, leading to blanching of the cheek. While this poor girl, the needle did not miss the facial nerve, so unfortunately she got some paralysis, but luckily it's temporary, and it is very important to know how to deal with it if it happens, and I hope it doesn't happen. So they vary from hypersensitivity, allergy, hematoma, trismus, pain, to even broken needle and the cardiovascular complications. Again, all these are operator errors. Later on, we'll talk about, is it a human error or negligence? There is a very fine line between both of them. The intraoperative procedure can vary from soft tissue injury, and this particular case, I witnessed it myself. It was a colleague of mine in 2008 in one of the UK hospitals. is a young girl. He was doing surgery under general anesthesia. We were double gloved at that time, and something went wrong with the handpiece. It got very warm and it caused a second-degree burn to the lower lip. And you can imagine what happened next. It was really, really difficult for him, for the girl, and even for all of us. So the other most important one is taking the wrong tooth out. It is very common error that can happen, and is considered in the United Kingdom as a never event. It's like simply amputating the wrong leg. I know it might not be as serious as that, but this is how it is considered. Complication can also go into the adjacent structure like the maxillary sinus by displacing roots or implants or instruments into the sinus, submandibular space, or even in the lung, as we'll see later on. Extraction can cause oroantral communication, and we'll see how to deal with that. It depends how big the defect is. Or also very common is fracture of the alveolar bone and the tuberosity. All these are common complications, but 99% of them could be avoided with proper planning. It goes without saying that bleeding is another important intraoperative and even post-operative complications. And a normal, competent dentist should be able to handle bleeding without the need to refer the patient to a specialist, unless he or she makes a serious error in obtaining a proper medical history, as we'll see later on. Another complication that not many people are aware of it is the surgical emphysema. I'm going to talk about it later on, and I'll show you some literature about it as well. The post-operative complications, again, they vary from bleeding and hematoma to post-operative swelling, pain and dry socket, infection, delayed healing, osteonecrosis, and also injury to the ID canal leading to numbness and paresthesia of the lip. So, having gone through all these complications, pre, intra, and post-operative, we must ask the question, how do we minimize that risk? It goes back to basics, detailed systematic medical history of the examination, make sure to perform all the tests are expected from you, tests like X-ray, MRI, CT, blood test if needed, even nerve testing. Sometimes we need to do that if we are examining things like T-major dysfunction or trigeminal neuralgia. Many of us tend to forget the culture and sensitivity test. We see a lot of pus coming out of infection in the oral cavity, and we just look at it and just don't bother. Usually, we should have a swab, send it to the bacteriology lab, and the lab would give us the results, including the sensitivity test. And once you drain an abscess of the pus, you really don't need to give the patient antibiotic if you properly drain that. But wait for the culture and sensitivity and then prescribe antibiotic if needed. Consider the preoperative one, depends on each individual patient. And sometimes we give dexamethasone in order to reduce post-operative inflammation. It's very important to know how to stop your bleeding. There are so many local measures, and we will also talk about them shortly. It goes without saying that we should use all the advanced technique like lasers and the PRF to help us not only to stop bleeding, but to improve the healing. So how do we improve our skills? Follow guidelines. We have something like NICE guideline, Royal College guidelines, American Heart Association guidelines. You can attend the professional training courses, and we provide many in our dental hospital here. You can shadow a colleague who's got better experience than you. or seek expert opinion or refer to a specialist. Your patient will respect you so much if you do that. As I mentioned earlier, we have guidelines which are systematically developed in order to assist the decision-making of the appropriate health care for specific clinical condition. United Kingdom are very fanatic about guidelines. We have nice guideline for wisdom teeth extraction, as you can see from this one. I think the latest one for NICE was 2017. We have guidelines regarding how to handle oncology patients, or guidelines how to manage trigeminal neuralgia, which we see it in the office from time to time, even guidelines for managing ectopic canines and perioradicular surgery. So there is no shortage of guidelines. And if we don't know, the internet is just an ocean of information you can always find out. So from poor clinical history, this is it's an example of how one can tend to ignore some important information. The 69-year-old woman referred from a general dental practitioner to a general dental practitioner for extraction of lower right first molar. Her complaint was simply a sharp broken tooth, and she suffers from rheumatoid arthritis, and she's unable to stand because of back problem, and she has no allergy. But the dentist never asked if she is on any medication. The intraoral examination showed a broken tooth and the lower right first molar with tender to percussion. The dentist consented her verbally and removed the lower right first molar and discharged the patient. Post-operatively, the patient continued to bleed. She suffered from bruises. Then she had to go, actually her son had to take her to the hospital. She was admitted, believe it or not, because she was never asked to stop the warfarin. In fact, she was never asked if she's taking any blood thinners or not. And she was given Fragmin, which is a low molecular weight heparin, and she was discharged back home safely after 3 days. And things like that could have been easily avoided with a proper history and the clinical examination. Also, failure to take medication, especially nowadays, which is they are very fashionable about these anti-resorptive agents for causing osteonecrosis of the jaw. You call it bronchium, there are so many names of it. The most infamous one is bisphosphonate, but there are so many other similar products. These products actually, they work in 2 ways. Either in simply they affect the osteoclastic activity, so the bone resorption stops, and also some of them affect the process of angiogenesis, which is a new formation of blood vessels. If you stop, this is especially for tumor treatment. Tumor usually need blood supply in order not only to grow, but to metastasize as well. So if you have this anti-angiogenic agent, the chance of minimizing metastasis or local spread is good, but at the same time, you compromise the blood supply. Now, it's noticed that the problem with osteonecrosis of the jaw, as you can see in these slides, is only happen in the jaw, in the mouth. I don't think I saw, maybe I missed it if it happened, but there is no report of osteonecrosis of long bones as a result of these medications, mainly in the oral cavity. Why do we give them? Mainly as anti-cancer, and usually are given IV, but also especially for women or who suffer from osteoporosis or other bone condition. We can give them also some of these agents like bisphosphonates in order to slow down the process and help on bone formation. The risk of osteonecrosis with cancer patient is much higher than those who are taking the drug for osteoporosis because the cancer patient dose is very high, and also they take it IV and usually for a long time. Other surgical complication, which I mentioned earlier, is surgical emphysema. For those who perform surgeries, you have to be very careful from using the three-way syringe in order to clean the wound, especially if there is so much blood. A lot of people do it inadvertently, which is very, very wrong. Once you open the wound and you reflect your mucoperiosteal flap, you are actually giving away to the air to go into the fascial spaces. Like in this particular case, you can see here that lady, she had endo in her lower jaw. And I think that, if I remember correctly, she also had episectomy. So after the surgery, although the surgery was successful, she suffered from subcutaneous emphysema. Is usually manageable, but it can be serious. So we have to be very careful. With dental implants, this is a typical case of malpractice of failing to manage patients correctly. If you look at this one, I think Jeff will agree with me that is not the intended place for putting this implant, or the way you place the implant. It shows here complete, not only a destruction of the buccal plate of bone, but also the mucosa. And this one, I mean, if you try to do it this million times, you'll not be able to do it intentionally, but the implant was placed on the periapical area of the adjacent tooth. If this is not enough, you can see implant into the maxillary sinus. And this is the one which is the most interesting one, is I think, if I'm not mistaken, this is a healing abutment. And again, because of lack of precautions, the patient swallowed that. And luckily she swallowed it, did not inhale it. Otherwise, the complication would be much worse. But all these could be easily avoided. And believe me, they happen, and they happen often. The other conditions that I'm going to talk about it in more detail, because this is the one that we do most here in the hospital, and oral surgeons consider wisdom tooth extraction is our bread and butter. Impacted lower third molar. As I mentioned earlier, NICE put guidelines, about 11 or 13 guidelines. When do we actually remove third molars? Now, removing it without any symptoms or without any reason is considered assault. It's in the United Kingdom, and we could be sued for that. So these are just some complicated positions of wisdom teeth. I'm not saying that general dental practitioners should not remove wisdom teeth. I never said that. In fact, if they are competent, they should do so. But some cases are very difficult, and they not only need a specialist with good experience, but sometimes they need a multi-team work in order to manage that. Also, doing this in a general dental practice is not really easy, because you would need at least conscious sedation or GA to deal with some of these cases. A case like that, if you do it under local anesthesia and they are not very careful, the chance of bone fracture is high, but also notice that there is a big cyst associated with that particular wisdom tooth. And if it's not this enough, you can see about 3 wisdom tooths in each side of that particular patient. And that one, which is in the ramus, again, I mean, this definitely needs GA, because the axis is very difficult. Usually we don't remove them unless there is a problem. And you can see here, there is a widening of the dental sac associated with that particular tooth, which means there's a possibility of cystic change or infection, but the patient was symptomatic. The problem with wisdom teeth is that patient complains of pain, sometimes swelling, but it's like any pain, and it's so important to try to do differential diagnosis, because we don't want to remove wisdom tooth when it is not needed to be removed. So it's very important to use all the diagnostic aids, especially CBCT these days, in order to not only find the position and the morphology of the roots, but also to see the association of the roots and the ID canal. And you're going to see a lot of pictures shortly. So do we need to remove every wisdom tooth? Of course not. You only remove them when they are needed, depends on the guideline. So if there is a caries, you can remove wisdom tooth, in the wisdom tooth itself or the adjacent tooth. And this particular one, I saw him myself. This was again in the UK. He's a 40-year-old male, and he had pain on the right side of his jaw for about 18 months. I remember this case very well because he was seen by a couple of dentists before they sent him to us, and they sent him to a plastic surgeon in order to treat that sinus. You can see that sinus here. And he had several, I think 2 surgeries in order to close that fistula, and it was not closed. When I examined him, there was no lymphadenopathy, but there was sinus and pus oozing. And the intraoral examination showed that there is a decayed tooth. And once this tooth and the adjacent ones were removed, believe it or not, the fistula healed, and there was no need to go to see the plastic surgeon for the 3rd time. So diagnosis is very, very, very important. The most common thing we see in our dental practice is pericoronitis. It varies from person to person. You can see how horrible it can be. It's extremely painful, and it can lead to many complications, which I mentioned earlier. Again, from pericoronitis, you can get spread of the infection to the adjacent structure, leading to sublingual, submandibular, and even submesenteric space. We remove also wisdom teeth for orthodontic treatment, even though if they are not symptomatic. And this particular case we done here, I removed these 2 little ones together with exposing the 2 canines. At the same time, this was done under general anesthesia. So NICE guidelines are very important to follow, or any guideline. It doesn't have to be NICE. I mean, the American board has its own guideline, but some cases are dubious, but these particular cases are not. Cases like this, you have horizontal wisdom tooth with a well-defined radiolucent area associated with that particular tooth, is most likely is a dentigerous cyst. Now, if you don't remove that, it's going to expand and maybe end up be as big as that, or even as huge as this one. So before we refer and before we act, it's so important, as I always say, go back to basics, assess patient, make sure to listen to the patient, and look for any supportive signs and symptoms in order to make a diagnosis. People usually, when they come to you from wisdom teeth, they have very limited mouth opening, and many of us are scared to ask the patient to open the mouth because of the pain, and they neglect actually to look there. We have to examine basic things like caries, pocketing, case of the adjacent teeth, any cystic chains, crowding, and so on. Complication can be serious, like this particular one. It's actually a colleague of mine did it when he was a registrar. He was a very strong man, and it just happened that he managed to break the jaw in this particular. This one was from a different hospital as well. So although it is extremely rare, but it can happen, and it's very important to know when to stop exerting such forces. This is another very interesting case. I think I mentioned about it earlier, is the burn of the lower limb. And it happens a lot for not taking the proper measurements to protect the soft tissue and the adjacent tissue. A lot of us, especially if it is a difficult case at the heat of the moment, you want to get it over and done with, especially if the patient is complaining or screaming. And we forget that the handpiece can get very hot, or the drill can actually affect the lip, and the patient obviously is numb because of the anesthesia, so he will not tell you to stop, or she will not tell you to stop. And this one is very serious, and it can cause a lot of problem for dentists. Again, fractures of instruments or displacement of instruments is not uncommon, and this is another important thing to teach us not to exert so much force when you use handpiece, or not to try to save money and always use disposable ones is better. Otherwise, it's going to cause a problem. And you can see this one is almost close or in the ID canal. After surgery complication, I mentioned some of them earlier, but one of the most common ones that sometimes they are not actually serious as they look. I think Dr. Muhammad Jamal and myself did a case together not too long ago, and even though we both assured the patient father that this is going to happen, but it's going to resolve, she was really scared the day after. But 1 week later, I saw her in the clinic, and she was absolutely fine. So complications do happen. You cannot expect a patient not to swell after surgical extraction, but tell the patient in advance about the possible complications. ID nerve damage is one of the serious ones. There's a lot of litigations about it in all over the world, and not only compensations to patients, but also can lead to disciplinary of the dentist. The paresthesia vary from 0.2% to 8%. It depends which part of the world you are in. And the anesthesia can also be between 0.3% to 0.8%. So it depends. There is a great variation, but I think it's technique sensitive. If someone is inexperienced, doesn't take the proper precautions, doesn't do the right investigations, CBCT, coronectomy, you name it, the chance of causing nerve damage will be higher than someone taking care of that. This is in Thailand. I like this very much, just to give you a break. Again, this is just a repeat of the previous slides. How do we minimize the risk? I'm going to talk about that. If you look at this particular, the next cases are all done here in Dubai, in Hamdan bin Muhammad College of Dental Medicine. I mean, it is not an easy tooth, but it's not a high risk, because if you look at the ID canal, it's just passing through that particular tooth, but it's not actually interfering with that. I have to admit we did CBCT, but I didn't put the picture here. And it's just a simple procedure with the experienced person. Just raise a flap, divide the tooth into two, take the crown out, then you can see the root here. And then once you take the root out, you can close, and it looks very good indeed. Sometimes can be very, very difficult. This was in the UK long ago, before we agreed to do CBCT for patients. It was myself and my colleague, we had to stick the roots back together with super glue in order to show the relationship to the nerve. It was not easy, I sweat a lot, but things happen. The reason I didn't put it because of this, I put it because when you look at a case like that, and in this radiograph, you say, okay, decayed wisdom tooth, widening of periodontal ligament space, it shouldn't be a problem to be elevated. But it was a problem because every time I attempted to elevate, it's very mobile. I tried to elevate the tooth and it springs back. I said, what is going on? And luckily, I split the tooth and I saw that the nerve is going between the roots. So I split the roots again, and it was okay. So the lesson we learned from this particular thing, if you are in doubt, it's very important to ask a colleague and make sure to do CBCT. CBCT now is available virtually everywhere, and the dosage from CBCT is not as high as normal CT scan. So in order to decrease the possibility of nerve damage, we have to, again, to go medical history, assess the patient, do the right investigation. If you know how to perform a coronectomy, do it. And if not, refer. And there are so many ways we can actually deal with that. Coronectomy is not the only one. Sometimes we have actually done that before. I referred the patient to orthodontist who managed to pull the tooth out orthodontically, and after a few months, it was too far from the nerve and they managed to remove the tooth. There are so many risks one need to take care of them, which simply the relationship between the apices of the roots and the nerve. I'm not going to go through all of that because of the time, because there are some other important things I need to show you here as well. But root morphology is very important, and it can complicate surgery. So it's better not to do heroic stuff, just do what you can if you are able to. But always better to refer. You can see this one and how it looks on the X-ray. What are the factors that affect the risk of nerve damage? Is the status of the dentition, the anatomical relationship to the roots, the opening of the mouth. If the patient is not able to open his mouth, whether because of trismus or scared or whatever it is, definitely it will compromise your ability to perform good surgery, even if you are very good. So luckily here at Hamdan bin Mohammed College of Dental Medicine, we have the sedation service, which is gaining momentum. It is our third year now, and it enabled us to perform surgeries that otherwise would have been difficult unless under general anesthesia. This is a colleague of mine, Vino. He works at Guy's Hospital. He published this with a group of the people working there about trying to characterize the relationship of the roots to the nerve. So even if you don't have CBCT, you can do your very best to at least discriminate between the high-risk cases which are close to the ID canal or interfering with the ID canal, or those which are not. And I give you some example here. This is just part of an OPG. You can see although the tram lines, which is the two lines here, were not absent, but still these two, after we did CBCT scan, we discovered that actually this is the groove in the roots, indicating that there were close relationship. Again, here narrowing of the ID canal. So there are some stuff we have to follow. But one of the ways definitely to reduce the risk dramatically is coronectomy. Coronectomy now is becoming very popular, which is simply you cut the tooth, whether wisdom tooth or another one, below the cervical line apically, and then make sure that the edges of the roots are underneath the bone. Remove the crown and just close the wound, and it will be absolutely fine. This is a case of done here of a young lady. She's about 31 years old. She came with severe pain. This is her wisdom tooth. Only the distal cusp you can see, and it is mesioangular, causing caries to the tooth in front. It was done under local anesthesia, actually not sedation. She refused sedation, and you can see I removed the crown here. Then this is the root that looks like a trunk of a tree. Once you cut it, you smooth it down with a round burr. Make sure, see here, the distance between the edge of the root and the alveolar crest. If you are happy with that, close, and your wound should fully tight and close. The patient went to another dentist because of pain, and he told her that you have a retained root, and they told her that the doctor who removed it for you doesn't know anything, but she told him no, it was a coronectomy and it was left deliberately. So it's very easy to jump into a conclusion without getting a proper medical history. This is just a summary. What do we do? This is, you raise a flag, you bevel it. This is the lingual aspect where the arrow is, and this is the buccal aspect. You bevel it, you cut the crown, remove it completely. Once you remove the crown, that piece with the gray line, use a round burr in order to take it down the alveolar crest. So you will have a root at this level, and then close after that. And this is how it looks after the surgery. Again, this was done here. But even though the coronectomy is very good and saved a lot of patients from potential nerve damage, sometimes we cannot do it even if it is close to the ID canal, simply because of infection or because there is a caries. And this particular one, when we did the CBCT, it showed that not only infection, but also there was a root caries, and I had to remove both of them. And this is a tooth, it was extracted, and then it was closed after that. Okay, almost there. I don't want you to go to sleep. This is a case that I was part of the investigator team here at the GHA. Is a gentleman from Philippines. His dentist did this beautiful periapical for him, and he was in severe pain, so she attempted to remove that wisdom tooth, which we don't know even the rest, how it looks like, the rest of that wisdom tooth. And under local anesthesia, if I remember the story correctly, it took more than 2 hours till about 9:30 in the evening, and the patient could not take it any longer. She tried to communicate with a colleague, she didn't find him. Then she tried to speak to Rashid Hospital in order to get oral surgeon advice. But to cut the story short, the patient left with a swollen face, and somebody else gave him antibiotic, and eventually he saw a specialist and had the root removed, or whatever remained of the tooth removed. She broke it, but she couldn't take the rest out. And she didn't know what to do because there is no X-ray. And you can imagine, I mean, really in front of the law, we have no leg to stand on. When I asked her, why didn't you do OPG? She said her answer that she wanted to save money for the patient. And this is really not acceptable. So it's really important to follow the guideline, follow the rules, and have proper instruments and have proper training in order to deal with it. This is a case that I saw here in the hospital with my colleagues here few weeks ago. Is a gentleman who came with his sister complaining of pain on the right side of his tongue. And he told me that he is dental phobic. He saw his dentist, and his dentist told him you have an abscess ulcer. And he used some mouthwash for several months. It did not work. Then he started to get a problem with swallowing. When he came to us here and examined him, I discovered that he's a heavy smoker. He smokes about 40 cigarettes in a day, which is quite a lot. He hasn't been seeing a dentist for a very long time. His oral hygiene was very, very poor. And you can see here is a grossly decayed lower right 7, I guess, opposite to that big ulcer. But you can also see the ulcer is a very significant feature. Look at the punching out nature of the ulcer. This one in particular as well. And it has a necrotic floor, indurated base, and the margins were a little bit everted. But the significant thing you notice also is that white slough around the ulcer and also the floor of the mouth and the dorsum of the tongue. I attempted to remove that slough. The one on the dorsum of the tongue, it was easy scrubbable. And in fact, I took a swab and sent it to the lab for cultural sensitivity because I suspected this is most likely going to be candidosis or candidosis. But these white lesions here did not, I could not scrub them off. And they were extending from the ventral surface of the tongue to the floor of the mouth, and also the lingual aspect of the mandible. I also noticed that the tongue movement of the gentleman was a little bit restricted. I did this OPG, and you notice opposite that, this is erosion of the bone in this area. So most likely the tumor, which I'm pretty sure it is one, is affecting the mandible. This is why he's got limitation of his tongue. I advised him to have urgent biopsy, but the gentleman did not come back for that. I also give him the swab in order to go to Mediclinic so we can prescribe him the correct antifungal or antibiotic. Again, he didn't come back to me, but he just he's phobic, and he is one of those people that, as they say, you can take the horse to the water, but you cannot make him drink. So, can we refer to a surgeon or not? This is very ethical question. Some people, they think that a patient will think of them that they are bad dentists if they don't refer. They have ego problem, and how can I refer to somebody else? I should be trying and dig in and do what I can. Some people also want to gain experience, even though I remember I spoke to a dentist in the EDIC last year, and he says to me that he's happy to do many of these surgeries because he saw them on YouTube. I couldn't believe it, but people do that. However, if you are a good dentist, you have to provide the best care for your patient. Patient should trust you. And if you refer the patient in difficult cases, he will respect you so much, and you will not actually lose the patient at all, because word of mouth generates more patients. It's very important to remember that our patient care should be patient-centered, patient in the middle, and everything should go around our patient. Sorry, I didn't mean this time. How do I stop that? Sorry, okay. Thank you very much. Dr. Iyad, where is he? Oh, here he is. I think it's just on time, good.
Thank you, Prof. Abdurrahman, for your very, very intriguing presentation, and it's relevant really to all. It's nice that it was peppered with very relevant clinical cases. That's things that we can encounter in our daily lives. So I've placed the link for the evaluation form for the CPD online for the online audience, and for those of you who want to collect their CPD points, please scan this QR code or click on the evaluation form link. I have a question for you,
Sure, yeah.
Prof. Abdurrahman, if that's okay. In terms of the patient that you showed in the end, the one with the potential cancer, oh, it looks like a squamous cell carcinoma. You said that the patient didn't attend anymore, so you've I assume that you've lost track of what happened to this patient.
We tried to contact him actually, but he didn't answer. Yeah.
Okay. So may I ask, did you actually inform him of the potential diagnosis at the time?
Absolutely, it's a very good question. Yeah. Thank you, Dr. Riyad, for this. Is very good question. A lot of people would not actually, but I was so honest with the patient, and as you know, in the UK, we are trained how to give bad news to patients, and you don't give bad news just like that. He has all the signs and symptoms that would make me suspect he has a cancer. He asked me, what do I think? And I told him, to be honest, I think it is a cancer, not abscess ulcer. Abscess ulcer would never ever look like that. He was not happy, but despite this, he did not come for follow-up. Yeah.
So just to follow up on the question on that, do you feel that he didn't follow up because of financial reasons, or was he anxious about this? Or was he in denial? And if it was an issue for financial reasons, could he have been referred to a government hospital at all for actually assessment and treatment?
Thank you again. Not really, not for. He's a businessman. He's a well-off person, but he simply has a dental phobia. He said he hasn't seen a dentist for a very long time. He only goes there when he is in pain. And the gentleman who told him he might have abscess ulcer, this was about 6-7 months ago. And then he saw him again, and then he referred him to us. It's not for financial reason at all, no.
Okay, thank you very much, Prof. Abdurrahman, for your presentation and for your response to the question there. There is no online questions at all, and therefore I close this session. I just remind the audience online to register. Oh, we have a question here. Sorry, we have another question. Sorry. Go ahead.
So about the do you think that the tooth will get erupt?
Sometimes, yeah. You mean the remaining root? Yeah, sometimes it does. Sometimes it does, yeah. But if it's done properly and there is enough distance between the top of the root and the crest of the bone, within 2 months, the bone will cover that and the tooth will not erupt. But if it is done just superficially and just sealing the root and leave it like that, most likely it can cause complication. Yeah.
Dr. Abdurrahman, there's an online question and from an anonymous person. How do you bevel in coronectomy?
With just direction of the Fisher bear, use a Fisher bear. You are actually, I showed it on the picture. I'm happy to put it again, but the fish, once you raise your flap, remove a little bit of bone buccally to not just a gutter in order to access that till you see the cervical line, and then you bevel the bear till you create your groove. Break the tooth. It should come as a clean cut, and after that use a round bear, and you'll be able to smooth down the other edge, and it should be fine. Yeah.
Okay, thank you, Prof. Abdurrahman. I do now definitely close this session. The online audience have asked their questions, and the present audience as well. Thank you so much, and would like to express our gratitude for this presentation. And we'll see you again see you all online or hybrid. Those who are in the audience here, we'll see you here again next month for our next episode of the GDP lecture series. Thank you.
Thank you so much, Dr. Riyad. Thank you, everybody. No problem. Thank you very much. Yeah.